My name's Ian Vela. I'm a urologic oncologist at the Princess Alexandra Hospital and a clinician researcher at the Australian Prostate Cancer Research Centre Queensland at the Translational Research Institute in Brisbane. I'll be giving a talk today on the current clinical management of prostate cancer and what's on the horizon. And this is a great opportunity for patients and clinicians and their supporters to get together and learn what's cutting edge and how we can help men with prostate cancer in Australia. I apologise, this is going to be a high view and rapid overview. I especially apologise to our translators, so I'll just get going. So I don't need to tell this audience about the importance of prostate cancer and that it is the most common lethal malignancy in men in Australia. There has been some variable coverage in media in the last few years about its importance, but we all know that this is a major health issue for men and their families. There's significant morbidity and mortality still with prostate cancer, and it's a very complex cancer regarding its grading, the treatment options, the quality of life issues associated with that, and also the clinical time frame that prostate cancer extends in men's lives. So unfortunately there is a lot of misinformation and confusion, and we will hopefully try and address some of those issues today. Mortality rates in Australia and the first world have been decreasing, at least to this point. We have some concerns with regards to the issues with screening that have been brought up in recent years, but we are making a major impact. So since my start of training in prostate cancer more than 12 years ago, prostate cancer has significantly changed how we manage it. It's now a risk stratified approach. We have active surveillance for men with low-risk prostate cancer to avoid over-treatment. We have intermediate and high-risk cancer being treated by radical therapy of curative intent. And older men or those with comorbidities, we institute watchful waiting, which I tell my guys is it's putting out fires if and when they occur. So with regards to detection, diagnosis and staging, PSA is still the backbone of early diagnosis and detection of curable disease, and it's still incredibly important. There are well-acknowledged issues with that, however, with specificity for cancer and high-grade disease, and so this has developed various new tests to try and improve standard PSA. I'll talk about those. Australia leads the way in imaging, and that's in detection, diagnosis and staging. And multiparametric MRI has revolutionised how we diagnose prostate cancer and also how we biopsy men. Active surveillance, however, is actively taken up by men in Australia and it's accepted by surgeons much more widely than other parts of the world, such as the US, which impacts on some of these new tests. So with regards to risk stratification prior to biopsy, there is a relatively new test in Australia called the PHI, or the Prostate Health Index, or PHI, you might also hear it referred to. It is available in Australia, it costs about $100 out of pocket, there's no rebate. It uses PSA with free PSA and an isoform PSA, which is calculated into a formula and spits out a number that essentially tries to risk stratify men as to whether or not it's likely to be a cancer or BPH that's causing an elevation. It is FDA approved. It's not particularly widely utilised in Australia, but it is available and can sometimes be helpful. With regards to men who've been biopsied, we can risk stratify now on the basis of genomic tests as to whether or not they potentially have a more aggressive disease than we think they do on just histology alone. The Prolaris cell cycle progression assay is available in Australia. It's very expensive. It's about $3,000 Australian. It's out of pocket. It measures the gene expression in what we call cell cycle progression genes. And it gives a report to the surgeon and the patient that essentially puts them on a risk stratification compared to men with the same clinical risk criteria compared to other men in that group. So in this particular chap, if you look, just try and work out where we are, this here is indicating that this particular gentleman has a higher genomic risk score than 94% of men in the same clinical risk category. And it also tells you that if we did nothing with this chap, in 10 years his risk of dying of prostate cancer is 2%. And if you consider that this is supposedly a chap with low to very low risk prostate cancer, he potentially has a more aggressive cancer than we anticipated from his biopsy or clinical data. And therefore this may be a conversation you have with this particular patient that maybe treatment would be better than an active surveillance protocol. An alternative genomic test is one called the Oncotype DX. It's also available in Australia now. It's $4,500. These all get sent to America, both these tests. Again, it's a different group of genes, but essentially it measures the gene expression in the biopsy tissue. And it gives you a report that essentially indicates the likelihood of favourable or unfavourable pathology if we performed a radical prostatectomy on that chap at this point in time. And in this particular example, this gentleman has an 83% chance of having likely favourable pathology at radical prostatectomy, and 91% chance of having no dominant pattern 4 or 5, which is the aggressive form of prostate cancer, and an 88% chance of having it confined to the prostate. So that could be a gentleman that you then are reassured that potentially you can continue on an active surveillance protocol. So these tests can be useful. Multiparametric MRI, however, has been a game changer in Australia, and we use a lot of MRI now in Australia. It's much more widely utilised in Australia than the US due to the fact that it's actually quite cost effective in Australia. We have also very high quality local data with work from Les Thompson and Morgan Hulkani in Brisbane indicating its utility, and also in the PROMISE study in the UK recently indicating its utility. We can reduce the number of biopsies potentially needed to diagnose men with significant cancer. We can target areas of suspicion, I'll talk about that shortly, and it provides substantial confidence that we haven't missed a significant cancer in men with low-risk prostate cancer, and we can watch them safely in active surveillance. We currently have a NSAC submission to the government, USAN's being the leader in that, to try and get rebate for MRI and MRI-guided biopsy to hopefully be no out-of-pocket for men in Australia for this sort of technology. So we're hopeful that this will get up and go. So we have a reporting system that we use with MRI called HIRADS, which is a reproducible validated scoring system so that everybody is talking the same language. It's essentially a scale of 1 to 5, 1 being very low risk of having significant cancer versus all the way up to HIRADS 5, which is a very high risk of having clinically significant cancer. It is, however, not foolproof. Unfortunately, 5 to 10% of men will have a negative MRI but still have significant cancer. So it's not a replacement for biopsy at this stage. So that's a discussion that needs to be held with the surgeons. So if we can see something, we can hit it. And we have a whole stack of new fusion biopsy technologies which improve your detection rate, decrease the number of biopsies you need to do, avoid side effects from excessive biopsies, and improve the confidence of knowing exactly what's going on in the man's prostate. And this improves the acceptance of active surveillance, which is very important so we don't over-treat low-risk cancer. And there's various different ways this can be done depending on the technology you have available and the skill of the surgeon. So I'll just give a quick example of one of my patients. So this is a 50-year-old chap who previously had a negative biopsy in his 40s due to an elevated PSA. So this is a very early elevation of PSA in this chap, and he's got a family history and a persistently elevated PSA. So he's at high risk of having a potential significant cancer. His biopsies, however, previously had been negative. So I did an MRI on him, and sure enough, he had a HIRADS 5 lesion, which is in the anterior gland area of the prostate, which is difficult to biopsy under standard techniques. So we have what's called the BioJet transperineal MRI ultrasound fusion biopsy technology at the PA, which is the only one in Queensland. And when I did that, this chap had actually 19 of 20 cores of his prostate positive for Gleason 4 plus 3 equals 7, which is significant cancer in large volumes. The remainder of his biopsies were either negative or low risk, indicating that this was why we previously missed this on using the standard technology. So this is a 3D rendering of the sort of thing that we do now. The red is the cancer, the green is the prostate, and the brown cores are where I've actually biopsied through the cancer. This is what it looks like in real time on the ultrasound machine, where I've pre-marked up the targets and where we've actually hit it. So this is new technologies, and it's really improving our diagnosis. So with regards to localised disease, in 2017, surgery and radiation are both standard of care. There's studies recently in both areas that confirm the efficacy of this for localised disease. Robotic prostatectomy has taken over in Australia and internationally, and there was a world first study at the Royal Brisbane Hospital. Jeff Coughlin and John Yaxley were the primary surgeons involved, which showed equivalence between the robotic approach and the open approach in early outcomes and major oncologic parameters. So the take-home message from this is that the surgeon, not the technique, is the most important thing. Longer-term data is pending. I tell my patients a monkey with a tool is still a monkey. Okay, so the robot is just a tool. If a man does not have access to a robot, either for financial or from where they actually live, they shouldn't feel that they're being cheated or getting less of a service if they have a good quality open surgeon. Okay, that's very important. So there's also a significant stage shift in the men we're treating now with surgery, much higher risk, higher volume disease than we ever did previously. With regards to radiation, it's an evolving technology. We now use androgen deprivation therapy in intermediate and high-risk cancers for variable times, and that's been shown to improve survival. There's all sorts of new technology coming on board in image guidance, proton beam, intensity modulation. There are shifting sands. We don't have a lot of long-term data for a lot of this technology, but we think, and the initial data is indicating that it's as good but probably better than our previous radiation treatments. And unfortunately, low-dose brachytherapy is actually declining significantly, and that's because those men who traditionally would be treated by LDR brachytherapy are now being put on active surveillance, so we can avoid treating those men altogether. HDR brachytherapy is still a very good option for high-risk disease. And then there's the concept of multimodal therapy, where we're actually performing surgery with radiation planned or discussed as a likely second-line therapy in high-risk disease. So we work very closely hand in glove with our radiation oncologist. And in my opinion, all men should be given the opportunity to discuss with a radiation oncologist and a surgeon to get a balanced view of what treatment options are available and what the right thing for them and their family is. So I think that's another important take-home message. Focal therapy is a concept where we're aiming to treat the index lesion and leave the rest of the prostate alone. These are all technologies that use some sort of energy to ablate the tissue, and there's various different versions of this. All of them aim to control disease and minimise side effects. In my opinion, at this point in time, these are all experimental. Okay? They should be in the context of a clinical trial, in my opinion. Most of the studies and the data we have is on low-risk disease at this point in time. And this is the group of men that we now know we can put on active surveillance, and they probably don't need treatment. And of course, they're going to do very well if we do treat their low-risk disease, because they're going to do well if we did nothing. So prostate cancer is also a multifocal disease. If you're just treating a part of the prostate, there's a very high likelihood that there are areas of cancer elsewhere that you may not know about and not treating. Also, we assume that the index lesion is the largest lesion that we can find. That we don't know that for a fact. Biologically aggressive cancer could be a smaller area that actually ends up going on to kill a man. So these questions still need to be answered. The follow-up and also salvage therapies, what are the side effects if we do need to do a radical prostatectomy after focal therapy in men? These are all questions that need to be answered. So I think focal therapy is not on prime time just yet. So we can't get away with prostate talk without molecular imaging, because PSMA PET MRI has exploded onto the Australian scene. It's also very active in certain centres in Europe, and the Americans are lagging severely behind at this point in time. PSMA stands for prostate-specific membrane antigen, and it's essentially a game-changing imaging technology that we are using. Essentially, it is much more sensitive and specific than our previous tests such as CT and MRI and also bone scans. Unfortunately, we're not sure how to interpret and what to do with this new data, because now we can see all these spots in the men, but what can we do about it? Our MDTs are full of these sorts of discussions, and there are trials being led by ANZUP and PCFA and at the Peter Mac that will be rolled out nationally, and Princess Alexandra and Royal Brisbane will be doing that to try and answer some of these questions. So in advanced disease, there's been massive and rapid expansion of available treatments in the last 5 to 7 years. ADT, or androgen deprivation therapy, is still the backbone, but once progression occurs, we've got an embarrassment of riches where we really had nothing previously. Enzalutamide and abiraterone are second-line therapies that have been shown to improve survival at 5 months in both pre-chemo and post-chemo space. In Australia, it's only approved currently in the post-chemo space or intolerant to chemo or predicted intolerance. So that's kind of up to the medical oncologist there. There is an application to try and get approval for the pre-chemo space, but that's pending. So we were moving towards trying to delay and avoid chemotherapy as much as possible, pushing it further and further back until along came Charted and Stampede, which are 2 major international trials. And this has again completely changed how we manage hormone-sensitive disease. And it's shown that in men with high volume hormone-sensitive disease, androgen deprivation therapy and chemotherapy improve survival by 17 months, and we've never seen survival gains like this in the history of prostate cancer. So the caveats are high volume disease on standard of care imaging, and that's bone scans and CT, not our new imaging. In low volume metastatic disease, we still do ADT, and then on progression we have abiraterone, enzalutamide or chemotherapy. However, there are still concerns about, we really don't know which order of drugs are the best. Should one be after the other, or should one come first? There's also emerging evidence to suggest that not all androgen deprivation therapies are potentially as good as each other, and the lower you can keep the testosterone, potentially that's better for progression. All of these drugs are very expensive. Chemotherapy is actually cheap, but it's toxic. So there's a lot of work still to be done as to working out exactly which men will benefit from which therapy at which time. The concept of oligometastatic disease is also developed, and that's minimal metastatic disease, and potentially this is a different type of disease. Can we potentially intervene in some men and treat them, change the natural history, or even cure some men? The molecular imaging has stage migrated a lot of patients where we couldn't find anything before. We're seeing these spots on these scans and putting them into an oligometastatic state. However, this could be potentially just the tip of the iceberg phenomena where you're seeing one or two spots and the chap will go on to blossom to multiple metastatic disease, or potentially there are patients with truly oligometastatic, only a few different spots that we can potentially try and treat. Metastasis-directed therapy, so that's surgery or radiation, has become a real buzzword. And our initial enthusiasm for this has somewhat waned after local and international results. And that's probably a sobering actual fact. We've also got to ask, what's our aim? Are we delaying systemic therapy or are we aiming to cure? Because they're two probably different scenarios. There's likely a very small number of men who will benefit from some of these aggressive management strategies, and many will not potentially be harmed due to the side effects of treatments. So at the current state of the art now, these should be performed in clinical trials so we avoid the Wild West phenomenon where we will just go out and treat whatever we can see, because a lot of men will probably be hurt and not benefit from that. There's ongoing international efforts to try and work out biomarkers to identify which men will benefit, and the Movember GAP6 trial, which I'm a member of, will hopefully be aiming to find new biomarkers to work out who will and who won't benefit from this sort of approach. There are some new drugs on the horizon. ARN-509, which is now named apalutamide, will be coming online, and there's phase 3 trials currently. It's another second-generation anti-androgen, similar to enzalutamide. Immunotherapy really hasn't taken off as well as we'd hoped. Sipuleucel T or Provenge is not available in Australia. It's a vaccine. It's extremely expensive. The checkpoint inhibitors, which you may be reading about or hearing about in prostate cancer, are nowhere near as effective as in other drugs. As in other cancers, sorry. However, there are some very exciting developments with PARP inhibitors. We now know that the DNA repair pathway is extremely important in both high-risk localized and definitely in metastatic disease. And there are new drugs on the market that will be coming out as we get the data in the future aiming at targeting this pathway. So FIGO or radium-223 is currently approved, but it's not funded. There's a bit of a argy-bargy going on between the drug company and the government about this. It does improve survival, and it's also very good for palliating bony pain, but it's bone-only disease. So that is available currently in Australia, but it's not. The funding issues need to be sorted out. We'll talk very shortly about theranostics and various other bits and pieces. So theranostics is a concept that you'll hear more about, and that's the concept of a radiopharmaceutical or chemotherapy payload delivered by a molecular target, and in this particular situation, it's PSMA. So the current trials, nationally and internationally, are looking at lutetium PSMA, which is a beta emitter. It attacks both soft tissue and bony nets. There's been some extraordinarily provocative initial results from Europe, which are really getting the field excited. These are in heavily pretreated men with very advanced disease, and I'll show you results shortly. We've got some, the next sort of version of this will likely be an alpha emitter called actinium. But unfortunately, you will need to have PSMA-avid disease, and in 5 to 10% of men with advanced disease, that's not going to be the case. They'll have a negative disease for this. So just as an example, this is a chap who's on his 5th line of therapy. This is a German group case report, who's got essentially what we call a super scan. His whole skeleton is lighting up like a Christmas tree. His PSA is 755. After 4 cycles of lutetium PSMA, his scan completely normalizes, and his PSA is undetectable. Now, we've never seen anything like this ever. So this is extremely exciting, but it's very early days. These are small numbers, retrospective, highly selected groups. But there will be a trial starting around Australia being led by Peter Mack, and Royal Brisbane and PA will be part of that trial. The toxicity appears to be reasonable at this point in time. So this is a real exciting time for men in this sort of scenario. So finally, we're going to talk about precision medicine, which is another big buzzword. And that talks about the right therapy in the right patient at the right time. So the idea is that we define tumours not on where they came from or what they look like under the microscope, but on their molecular subtypes. So we aim to identify new molecular aberrations that you can find new therapies and potentially improve outcomes in specific patients. And we'll be able to serially assess patients over time with either blood or bone and bone biopsies, and modify their therapies as we work out how the cancer adapts to therapy. So we have a clinical trial that's being led by Dr. Andre Joshi here at Princess Alexandra, looking at state-of-the-art imaging, and part of the trial is also looking at a precision medicine approach to early recurrent cancer, where we take biopsies of the man, we grow them in the lab, We do drug screening, and we also do genomics and transcriptomics to try and predict what drugs the patient may respond to. So this is an example of a chap who's had biochemical recurrence after radical prostatectomy. His bone scan and CT showed a suspicious node, which the biopsy was inconclusive. His bone scan was negative. We did a PSMA PET MRI, which showed a positive node. After discussion at our MDT, he had a salvage lymph node dissection. So this is his, you can see how impressive these scans are. They light up very, very obviously. And this is on the MRI. So we grew this in the lab for 4 weeks, and it was PSA positive, which is a marker of prostate cancer, as you're aware, and a gene expression was consistent with cancer. We did drug screening in 2 dimensions and 3 dimensions, and what we found here was that anti-androgens really didn't do too much to this cancer, however chemotherapy did. When we did it in 3 dimensions, which is more representative of the in-the-body scenario, again, anti-androgens didn't do anything to the cancer, but chemotherapy did. And hot off the press, we've actually we've just got the sequencing back, and it appears that this chap has an androgen receptor splice variant, which makes him resistant to these anti-androgens, and potentially indicates that he would be better treated by chemotherapy instead of an anti-androgen therapy. So this is the concept that we're trying to get with the precision medicine approach. So in conclusion, it's an exciting time for us as clinicians and you as patients. We've got massive gains in all facets of cancer biology, diagnosis and treatment. It's a rapidly changing landscape. Things are changing faster than we can keep up, and we're the ones trying to lead the way. So we're well on our way to improving outcomes, but we're not ready to take a rest just yet. So these are my funding partners, and obviously PCFA and Movember are incredibly important to researchers and clinicians like myself, and without them we couldn't do any of this sort of work. So thank you very much.